Welcome. My name is Stephanie. I've seen some of you guys before. I am a current fourth-year medical student at the University of Iowa, graduating this spring, and I'll be going into internal medicine. So thyroid disorders, right up my alley. Lots of endocrine stuff in internal medicine. All right, so for those of you who are new, these sessions are just case-based learning sessions, so we encourage active participation. There should be a sub note that you have. Let me know if you don't. You can feel free to fill this out however, as much as you want, or you don't have to fill it out if you don't want to as well. You could take just notes on your own. But yeah, let me know in the chat if you guys don't have access to this. Otherwise, all right, so let's get started with our case. So I'll just go ahead and read this, and you guys can take notes as you go, or just be thinking about some of the pertinent positive and negatives that we have here. So Brianne Pendergast, she is a 24-year-old woman. She comes to her primary care physician in September because she's tired, irritable, and she's had some sweatiness. She's from Michigan, but she moved to Florida this past June to begin teaching social studies at an elementary school. It's her first teaching job since graduating college. Since the move, she has been feeling very tired and irritable. She's finding it difficult to adjust to the Florida heat. She says that she's frustrated with her landlord currently because the air conditioner in her unit doesn't make her bedroom cold enough for sleep. She additionally reports intermittent episodes of a racing heart, sweaty palms and feet, and generalized feelings of anxiety. So, what are some of the pertinent positive and negative symptoms that we have here? And when I say positives, I say symptoms that make you think of like a certain diagnosis, versus maybe negative is the lack of a symptom or the presence of a symptom that moves you away from a diagnosis. Mostly positives here. Racing heart, right? Yeah, that's a little concerning. She's tired, irritable, sweaty. Yeah, exactly. With the tiredness, yeah, feelings of anxiety, great, yeah. So let's actually, I think I have, oh, I should go, I don't know why. Yep, so tiredness, irritability, sweatiness, again, tired and irritable. She is very hot. Her bedroom has not been cold enough. So either, her air conditioner is not working, or she's just overwhelmingly hot. Episodes of racing heart, and then the anxiety. So great, good job. So what other things do we want to consider? Knowing those are just some general symptoms she's coming in with, what other things do we want to ask about? Or is there more that we want to know about the symptoms? Yeah, great. Somebody had said in the chat, asked more about her mental health to understand if she's experienced anxiety in the past. That's great. I think that's wonderful. That's one of the first points that I made, was like, yeah, lifestyle factors. So like mental health falls into there as well. How's her mood been? Has she experienced this in the past? Has anything, triggered this? Is she dealing with anxiety from the mood? Yeah, if symptoms are constant or they're triggered by certain scenarios, great. Yeah, are they constant, or do they just kind of come and go throughout the day? Has she noticed anything happening before the symptoms come on? Great. So yeah, and more into the sleep, like she's very tired, right? So fatigue is a pretty non-specific symptom. It can be present in a variety of conditions, and it can just be like normal these days anyway. If you're a teacher, you're probably tired from working with students all day. But probing a little bit more into like her sleep routine, Is she going to bed early enough? Is she falling asleep right away? Does she wake up in the middle of the night? That's helpful too, as well as like diet and exercise. What else? Let's see what I put. So just general, as we always ask, the past medical history and family history, which we'll get to. Associated symptoms. So I think somebody had mentioned, has she had these symptoms before? Has she had a history of mood disorders or mood concerns? Racing heart. So any other cardiac symptoms would be helpful to ask about, with the racing heart. Does she experience any chest pain, shortness of breath, or is it just like, my heart feels like it's beating fast sometimes? Any recent illnesses, that's always important to ask about. And then, other general questions. So just a reminder that, being tired and fatigue is a pretty non-specific chief concern that patients have. All right, so let's get a little bit more information. So Brianne states she's noticed herself becoming more impatient with her students when they ask to have instructions repeated or when they cannot understand something that should be simple. This worries her because one of her strengths as a teacher has always been her patience. She's beginning to wonder if maybe she is not cut out for this job. She's tired during the day from the energy her job requires, as well from the struggles that she's having with sleep. So in addition to her room being uncomfortably warm, she struggles to fall asleep. She goes to bed around 10 p.m. every night, but she does not fall asleep until midnight. She endorses a 7-pound weight loss over the past 6 weeks, despite the fact that she's eating more than usual. She missed her last menstrual period, but she's not currently sexually active. She denies chronic health issues, and she's not taking any medications besides a multivitamin. All right. So what other information is important from this paragraph? Yes, weight loss. Yeah, that's pretty concerning, especially since she says she's, eating more. So weight loss, what else? I'd already highlighted that becoming more impatient with her students. So I think that's important to ask about because, she's noticed a change in her mood, and that doesn't always have to be, something related to necessarily mental health, but there could be an underlying, medical condition that's also causing these concerns, right? So what's normal versus what's not normal. It's normal sometimes for teachers to be a little bit stressed about things, but this is obviously concerning to her. So we know that it's probably a great change from her baseline. What else? Struggles to fall asleep. Yeah, absolutely. So she's experiencing some insomnia, it sounds like. So having difficulties with actually, sleeping. So not only is she tired from her day job, but she's having issues going to bed. Missing her period. Yes. So that's an important one too, because we know that she's not sexually active. So, and she's eating more, things like that. So why is she missing her period? Great. So yeah, I've highlighted all of those. Oops, come on. There we go. Yep. All right. So some additional history for her. It says no past medical history, as she's already said. She's not taking any medications, doesn't have any allergies. It looks like for family history, her maternal grandfather died of a heart attack. Her mother and father are both in good health. She has one sister, and her sister has type 1 diabetes. She has no children. So she lives in Florida. She's an elementary school teacher. She teaches social studies. She's single and lives alone with a cat named Pepper. She exercises 3 to 4 times per week. She runs or rides a bike. She enjoys watching Netflix and baking desserts, and she doesn't use any drugs or alcohol. Anything from this that sticks out to you, or something that could potentially fit with her symptoms or that we might pay attention to? What do you think about her sister's history?
Yeah, that's pretty concerning because that could be an indication of diabetes, especially with irritability and weight loss, especially since she does take off
Yeah,
weight.
yeah, absolutely. Great point there. Exactly. So some of her symptoms, a lot of these symptoms that she's having still kind of feel a little non-specific, and they do kind of fit this, they could potentially be explained by diabetes. I think too, do you guys know what kind of, I guess this is more like guess what I'm thinking, but do you know what kind of medical condition type 1 diabetes is? Do you know like how it
I
comes to
believe it's
be?
autoimmune.
Yes, good. Yeah. So it's autoimmune, exactly. And so that tells us that, there's a family history of autoimmune diseases, and we know that autoimmune diseases do have some genetic underpinnings. And so perhaps, she is at risk for autoimmune conditions herself, that since her sister has an autoimmune condition. Great. So that's the point I wanted to make there. And, it does look, as far as lifestyle factors go, that she is, exercising, and she is having some, social stuff in her life. She likes doing fun things like baking desserts. She has a pet, doesn't use drugs or alcohol. So, that seems all relatively normal as well. Okay, let's go on to the next page. Okay, so here's her physical exam, and I'll just let you guys look over this. Let me know if you have questions. This picture here that I'm pointing out with my mouse is of her neck area, of the thyromegaly, or the enlarged thyroid that we see on her HE&T exam. Okay, are there some things that stick out to you guys? Let's look at vitals first. What about vitals? Anything stick out to you? Yeah, mildly tachycardic, exactly. Not too terrible, but we would expect, if she was resting and whatnot, for her heart rate to at least be under 100. What else? So yeah, a little bit of a higher blood pressure, right? That could be, the quote unquote white coat syndrome. Maybe she's nervous. She does say she's anxious in general. It could just be maybe she was walking and then sat down. That could also explain her tachycardia, but high blood pressure as well could be part of the issue. What other things? What about her neck exam? Anything concerning with this HE&T? Yeah, the thyromegaly, exactly. So she does have some enlarged thyroid that is felt, but they don't say that I guess, well, the clinician, it's supposed to be us that is doing the exam, but we're not palpating any masses though, or any like little nodules in it. It just seems to be enlarged, and it's not tender. So that's important to take note of. And then she doesn't have any enlarged lymph nodes either. And then I think that's pretty much anything with the neuro exam that might be abnormal. So it says she has 3+ deep tendon reflexes. That just means really, sorry, that was my email, but that just means really strong reflexes. So it's hyperreflexia. Hyperreflexia can be indicative of certain disorders with our central nervous system. Specifically, when people have strokes up into the higher areas of the CNS, they can present with hyperreflexia and things like that. But in her case, it is quite normal for younger women to have hyperreflexia, especially if they're, anxious and there's a lot of sympathetic nervous system activity going on, then that can be a normal finding, but just something to keep at the back of our mind. Okay, great. So pointed out all of those, wonderful. So let's summarize. So she is a 24-year-old elementary school teacher. She doesn't have, any remarkable past medical history. And what are her general symptoms that she has? Just getting everybody on the same page. Can we remember? Great. Yep. So fatigue, wonderful. Fatigue. What else? Feelings of anxiety. Yeah, exactly. A little bit of irritability, insomnia. She's got that sweating and that heat intolerance. So even though she has an air conditioner, either it's not working or she's just really, really hot. She does say her palms are sweating a lot. The racing heart, as we had mentioned, and then the menstrual irregularities and the weight loss, right? Great. So, and then the exam, we had just gone through that. So I'll run through that. The tachycardia, the increased deep tendon reflexes, which could be normal. And then the thyromegaly, which is our big finding on our exam. So with that being said, what do these symptoms and exams findings indicate? Specifically, when you guys look at this stuff and put it together, is there any sort of like hormone or organ system or something that you think of that could explain all of these symptoms maybe? Yes, great. Yeah, thyroid. Exactly. So the thyromegaly is a little concerning because it's enlarged. People can have, larger than normal thyroids, but this one is supposed to be, pretty enlarged in her. You could see on the picture that it was noticeable, when looking at her neck. And so that makes you think, yeah, something is probably going on because it's probably related to her symptoms, not just an incidental finding. So the thyroid hormones, are they involved in, some of these symptoms? Are they involved in like heat, heart rate, weight, maintenance, menstruation? What do you guys think? Yes or no? Yes, yeah, exactly. So thyroid really, those hormones are very important in metabolism and in energy. And so all of these symptoms can be explained by perhaps a dysregulation in her thyroid hormones. Great. All right, so now that we think like we're kind of thinking about thyroid is probably our issue, but we don't know specifically what is wrong with the thyroid. So what do you think perhaps would be our first step in evaluation? Something that's really easy to do. People get them all the time for various things, just to give us some more data. So kind of, I guess, what I'm thinking too. But if you guys have any thoughts about the first thing that we might do. Blood work, perfect. Yes, blood work. So we could actually measure thyroid hormones in the blood. Additionally, we can measure a hormone that is produced by the anterior pituitary gland, which we'll talk about. So we should do that. So those are T4 and T3 are our thyroid hormones, and then TSH is a hormone produced by the anterior pituitary gland. And then we can also just check a metabolic panel as well as just a regular CBC, complete blood count. Those are easy, those are cheap. It could also just help in, is she tired because she's anemic, all of those kind of stuff. Okay. So let's pause for a bit and we'll talk a little bit about the thyroid before we move on. So thyroid hormone, as I've already alluded to, is involved in a variety of metabolic processes within the body. So some of these include like brain maturation, bone growth. It has sympathetic nervous system activities on the heart. They're called beta adrenergic receptors that the thyroid hormone will act on, and that will increase heart rate and contractility of the heart. It helps it to pump better. Thyroid hormone is involved in metabolism. It increases your basal metabolic rate. Thyroid hormone is involved in the utilization of blood sugar as well as the metabolism of lipids, which is called like lipolysis. So just a lot of things going on here. Then you also see here too, like the body temperature as well. Could explain why she's feeling, hot all of the time. Okay, so the thyroid gland, it's at the base of the neck, and they often call it like butterfly shaped, quote unquote, and it does kind of look like a butterfly here. This gland is responsible for producing and releasing those thyroid hormones. So within this gland, T3 and T4 are produced, and then they can get sent out throughout the bloodstream and act on target organs and do all of their, metabolic processes. So yeah, as I said, the hormones produced are T3 and T4. Now, what tells the thyroid gland to make T3 and T4? Well, that's a great question. So there are two areas of the brain, the hypothalamus and the anterior pituitary gland, and posterior, but we're talking about the anterior portion in today's session, that are very much involved in like regulating the endocrine system. So the hypothalamus, in regards to the production of thyroid hormones, the hypothalamus is going to release something called the thyrotropin releasing hormone, or just TRH. So TRH acts on the anterior pituitary and tells it to release TSH, or thyroid stimulating hormone. Then thyroid stimulating hormone is in turn going to go over to the gland, the thyroid gland, and say, hey, make, T3 and T4. And so then the thyroid will make T3 and T4. So when we don't have enough of T3 and T4 around, that's what's going on. Now, when we have a lot of T3 and T4 around and the thyroid gland is making a lot of that, there'll be a negative feedback loop, right? Because we want to keep everything in balance. We don't want to make too much T3 or T4. And so what happens then is the production of TRH and the production of TSH will decrease when there's enough of this floating around. Does that make sense to everyone? Endocrine can be a little confusing, but the negative feedback is really important in like maintaining, a steady state and like equilibrium and the amount of hormones that we need, and not too much or not too little. However, so there's the pathology arises when we have too little thyroid hormone or too much, right? When we're out of balance. And too little is called hypothyroidism, and too much is called hyper. So thinking about this axis, we call it the HPT axis. It's the hypothalamus, pituitary, thyroid axis. If there's something wrong with like hormones, like too little or too much are being produced, the problem can be at various steps along this pathway. So the problem could potentially be that the thyroid gland is either overproducing or not making enough hormones. Or it could be that the pituitary gland is not sending signals to tell the thyroid gland to make hormones, or maybe it's sending too much signals to tell the thyroid gland to make hormones. So we call that, central when it's in the brain, central or secondary hyper or hypothyroidism, versus primary hyper or hypothyroidism when the issue is within the gland itself. Are there any questions about that? Okay, great. Okay, so this is just a very busy slide. Obviously, we're not going to walk through all of these steps. I just wanted to show how, it's really complex about how thyroid hormones are actually made when TSH acts on the receptor and then causes the thyroid to make the hormones. So notably, what I wanted to bring to your attention is that iodide is a really important mineral in making thyroid hormones. So it's pumped into the cell by this symporter, and then an enzyme called thyroid peroxidase will oxidize it and then incorporate it into different residues of these thyroglobulin molecules and release the thyroid hormones into this colloid, which is like the middle of these thyroid follicular cells. And then ultimately those hormones will be sent out into the bloodstream. So yeah, that's just kind of an overview of what happens. I just wanted to make a point about iodide being very important for thyroid function. Additionally, this enzyme, this thyroid peroxidase, is often a target of, different medications when we treat an overactive thyroid because it's involved in the synthesis of hormones. So if we're making too much, we can use drugs that block this to help turn that off. Okay. And then, so talking about hypothyroidism versus hyperthyroidism, with a reminder that hypothyroidism is too little thyroid hormone and hyper is too much. You can see the different manifestations here. So over on this side of hypothyroidism, not having enough hormone, since it's involved in metabolism, we can see that, somebody with hypothyroidism might be at risk for weight gain. It can cause constipation. They can start to get a swollen face, fatigue, memory impairment, depression. Their thyroid can be enlarged, similar in hyperthyroidism. They can have a slow heart rate, right? Because thyroid hormone acts on the heart to increase heart rate. And so if we don't have enough, that's going to slow it down. And then dry, rough skin. Whereas on the other hand, with hyperthyroidism, this kind of ramps up our metabolic activity. It ramps up our system. So patients will come in and have, they'll say, I've been irritable, I'm really nervous, can't sleep, maybe some weight loss, diarrhea. They often have an increased body temperature. They sweat a lot. They can have muscle cramps, increased heart rate. And then also, their thyroid can be enlarged. So our patient, does she likely have hyperthyroidism or hypothyroidism? We haven't gotten the labs back yet, but what do you think? Yeah, hyperthyroidism, right? So all of her symptoms kind of fall onto this side of the spectrum. So she probably has too much thyroid hormone. Okay, so the first step in workup, as we had mentioned, would be to check the thyroid hormones, so T4 and T3, and then check the TSH. Remember, TSH was made by that anterior pituitary, and it's elevated when we need to make more thyroid hormones because it tells the thyroid to make hormones. So let me ask you a question. So if this patient's problem, so we know we haven't seen her labs yet, but she's probably hyperthyroid. If her problem is within the thyroid gland, would we expect the T4 to be high or T low or low? She's hyperthyroid. So would we expect the T4 to be high or low? And remember that T4 is a thyroid hormone. And so she has hyperthyroidism, right? So the T4 is probably going to be high because we think she has high thyroid hormones. So if the problem was with the gland itself, though, just producing way too many hormones, do we expect the TSH to be high or low? Remember, the TSH is released by the anterior pituitary. It acts on the thyroid gland to tell it to make hormones. If the thyroid gland is just by itself cranking out a ton of hormones, what do we expect this level to be, high or low? That's a great guess. Yeah, high is a great guess because, sometimes you can have the problem be with the anterior pituitary? So great guess, but it would actually be low. So let me explain this and tell me if this makes sense. Okay, it can be a little confusing. Endocrine can be confusing. But if our problem is with the thyroid, let's say the thyroid itself has an issue and he's just cranking out all of this T3 and T4, all these thyroid hormones for no reason. Your body sees that and it's like, whoa, dude, stop. And so the anterior pituitary gland, which normally tells this guy to make hormones, he's like, bro, you need to put some brakes on that. And so he doesn't release as much TSH because he's trying to get him not to release hormones, right? So TSH would make the thyroid release more hormones. So when we have hyperthyroidism and the problems with the thyroid, then we want our TSH to be low because our body's trying to tell the thyroid to slow down. Does that make sense? Yes, no, maybe. Okay, well, we'll go ahead and try. Yes, great, yeah. Takes a little bit of kind of thinking and wrapping your head around it, but it's always a good, reminder to remember that the body likes to stay in equilibrium. So if there's a problem with any specific point, the rest of these guys are trying to, combat that by doing the opposite. So he's trying to tell him to slow down. Okay, great. What if the problem was with the pituitary gland? So we still have hyperthyroidism. So there's too many thyroid hormones being made. Would our T4 be high or low? Hyperthyroid still hyperthyroid. So is our thyroid hormones high or low? So they'd be high, right? Because we're still hyperthyroid. However, in this case, if the problem is the pituitary gland telling the thyroid to make way too many thyroid hormones, that he's just saying, hey, make the hormones, and he's super unregulated, is our TSH going to be high or is our TSH going to be low? High, exactly, yeah. So the anterior pituitary, if the issue was with the pituitary or the brain, that means our TSH is high because the problem is that we're just telling the thyroid to all the time to make these thyroid hormones. So our TSH is high. So you still get hyperthyroidism, but the problem is with a different area, right? It's up here in the brain now. Whereas when the problem was with the thyroid causing hyperthyroidism, we had a low TSH. So the reason we do this is, question. Yes, wonderful question, Avery. So she asked if the problem was with the pituitary gland, could the underlying problem be with the hypothalamus because it stimulates the pituitary gland? Yes, absolutely. So I didn't put that question in here to have you guys think through, but it would essentially be, an elevated TRH, elevated TSH, and then elevated thyroid hormones. All of them would be elevated. An issue with the hypothalamus itself causing these, hyperthyroidism is less common. It's more rare. An anterior pituitary tumor can do this, and that's more common as far as which parts of the central nervous system can cause hyperthyroidism. But certainly, I like that you're thinking about that because that could be an issue as well. Great. Yeah. Okay, so yeah, and so the reason I bring this up is that when we are having a patient that presents with hyperthyroidism, we need to ask ourselves, where are we at? Where's the issue probably, right? And what can help us determine that is the labs, right? We can see here that if we drew her labs and T4 is high and TSH is low, that indicates the problem is likely with her thyroid. Whereas if they're both high, the problem is likely, in the brain, either the hypothalamus or the anterior pituitary. Now, when we talk about issues within the thyroid itself, these can be Graves' disease, which is an autoimmune condition that tells the thyroid to produce too many hormones. This can be toxic multinodular goiter and toxic adenoma. These are just either a single or multiple little nodules within the thyroid that are overactive and they tell the thyroid to just keep producing hormones. Or we can have something called post-viral or postpartum thyroiditis. It's just essentially an inflammation of the thyroid. And you go through certain phases, but the first phase is because it becomes inflamed, then you just release all of this thyroid hormone that's already been formed. And so the patients become hyperthyroid transiently. Now, if the issue is within like the pituitary, this can be like a tumor, as I was saying, or even up in the hypothalamus, maybe a tumor or stroke. I mean, I don't know. It's more rare, so I'm not sure exactly what the etiology of that would be. But great. Okay, so finally to our patient. So laboratory results, her CBCs, or her blood count, and her metabolic panel were normal. However, her T3 was 210. The normal is 95 to 190, so high. T4 is 15. The normal is 5 to 12, so also high. So it looks like her thyroid hormones are high. And her TSH is 0.03, which is low. So does our patient have a problem with the gland itself or with the pituitary hypothalamus? What do you guys think based on these labs? Her thyroid hormones are high, but her TSH is low. So pituitary gland, that's a great guess. So remember, pituitary gland, would we expect if the problem was the pituitary gland telling the thyroid to release a bunch of thyroid hormones, would we expect the TSH to be high or low in that case? We'll go back to this slide real quick. So right here. So our thyroid hormones are high and our TSH is low. So is our problem with the gland or with the thyroid gland itself or the pituitary? Thyroid gland, great, yeah. And great, thanks for the participation. Doesn't matter if you have a wrong answer, that's totally fine. We're all learning, so that's great. Yeah, so we would expect the problem to be with the gland itself, because remember, when you're making too much thyroid hormone from the gland, like the gland is out of control, then your anterior pituitary is going to shut off TSH. It's going to stop sending TSH because it wants the thyroid to slow down. The thyroid's not listening, it's continuing to produce those hormones, but the anterior pituitary is trying to tell it to shut down. Whereas if the problem is with the anterior pituitary, the problem itself would be that the pituitary gland was just producing way too much TSH and telling the thyroid to make too much hormone. So that's why those would both be high in that situation. So gland itself. So that being said, our differential then includes potentially she has Graves' disease, maybe a thyroiditis, like post-viral thyroiditis, or maybe she has a multinodular goiter or a single toxic adenoma. So let's talk about these things before we know what to do next. So these are all primary hyperthyroidism because they're all issues with the gland itself. So Graves' disease, as I had mentioned, it's an autoimmune disease. It's the most common cause of hyperthyroidism. So what happens is it produces autoantibodies that stimulate these receptors on the thyroid gland and tell it to make a lot of thyroid hormones. Patients can also have, they often have an enlarged thyroid. It's called like goiter. And they also have what this ophthalmology, Graves' ophthalmology, it's called exophthalmos, like protruding of the eyes. And we can talk about the mechanism for that a little bit later. And they can also get some edema of their lower extremities. And then toxic multinodular goiter or a single adenoma, as I had mentioned, is just like having one nodule or having multiple along the thyroid. And these nodules are hyperfunctioning. So they're making a lot of thyroid hormones. It's often due to having just receptor mutations in the thyroid. And it's more common in areas of low iodine intake than it is in the United States. And then our last but not least is our thyroiditis. So this is like after having a viral infection. Sometimes it can be caused by pregnancy. And so it's inflammation or destruction of the gland. And you go through a couple phases. So the first phase is just this rapid release of a lot of thyroid hormones and causing hyperthyroidism as the gland starts to become, inflamed and destroyed. Then ultimately, once all those are released, because your gland is no longer making thyroid hormones, you have this hypothyroid phase. But then ultimately, they usually recover. Okay, so just thinking with our patient, kind of what we saw on exam and everything like that. And also I want to mention too, sorry, for thyroiditis, the thyroid is also going to be enlarged, but it'll be really tender. Okay, and they'll often, like, if it's post-viral, of course, they will have had an illness prior. So thinking back to our patient, of these, differentials for primary hyperthyroidism, where do we think she is? What do we think maybe her problem is of these three? Was her thyroid tender? You guys remember? No, right? So maybe less likely thyroiditis. I don't remember her having an illness, right? Did we feel any like nodules in her thyroid? Or was it just enlarged? Yeah, just enlarged. I don't think that we felt any nodules. Great. So maybe, less likely this single adenoma. Also, we know that Graves is the most common cause of hyperthyroidism. And remember, her sister had a history of autoimmune, disease through type 1 diabetes. So potentially, she could be at risk of having this autoimmune condition as well. So we'll see. I think, Graves was probably highest on our differential right now. Okay. So how do we, though, decide and prove like which one she has? Because we've already proven that she has hyperthyroidism and that it comes from the thyroid gland, right? Because TSH is low and the thyroid hormones are high. So if in Graves' disease, you already see those protruding eyes, you see that edema, all of those signs of Graves' disease, usually you can just go directly to treatment. If you have already established that the patient has hyperthyroidism. In our patient, we didn't really see anything with her eyes. There was no like pretibial myxedema or the edema of the legs. So we're not as sure. So then the next thing that you would do is you can test a blood test for TSH receptor antibodies, because those are the antibodies that cause that reaction, that was autoimmune reaction with the thyroid that ends up telling the thyroid to make more hormones. So if those are positive, then it's very likely that she has Graves' disease and you can just treat from there. However, if that was negative, but you were still concerned that she had Graves' disease, what we do is we use nuclear medicine scans, as well as radioactive iodine uptake measurements. So those do two things. So the nuclear medicine thyroid scan is going to tell us about the distribution of the function of the thyroid. That's helpful because if we know that the thyroid is over functioning, then we ask ourselves, is the whole thing over functioning, or does it have only discrete areas where it's over functioning, such as those little nodules, like in the toxic multinodular goiter? So that's what the scan can tell us. And the radioactive iodine uptake test just tells us we administer radioactive iodine, and then it can tell us how much of that is uptaken by the thyroid. It essentially just tells us, is it over functioning or not? It gives us a percentage of radioactive iodine that's taken up. So like coupling all that together, and we'll see pictures of this on the next page. It can be confusing when I'm just talking about it, but all together that can help us differentiate, which three of these is likely going on. Okay, so talking a little bit more about the radioactive iodine in the thyroid scans. So with our patient, we think she has Graves' disease. She doesn't have these classic signs, so we could go ahead and test the TSH receptor antibodies. If they're positive, we don't have to do the scans. Now, for learning purposes, I just pretended that we are going to do the lab as well as the scans, but know that if this came back positive, you wouldn't have to do the scans. Well, let's talk about them. So the first one, the radioactive iodine uptake test, it tells you about the function of the gland. Are we over functioning or are we under functioning? Now, our labs already give us that sort of indication, but this is helpful in just quantifying that. So remember that the thyroid needs iodine to synthesize thyroid hormone. So what happens in this uptake test is you give a patient a small dose of radioactive iodine. You then measure the percentage of that dose that is taken up by the gland at like 6 and 24 hours. The normal uptake is about 25%. If you do have an overfunctioning thyroid, like in Graves' disease or the toxic multinodular goiter, there will be a larger proportion of uptake. It'll be greater than 25%. Thyroiditis, if the membranes are damaged, it can, and you're outside of that hyperthyroid phase, it won't take up any of the ingested dose. So the uptake will be about 0 to 2%. So that can kind of give us a clue into like which of these is going on. Now we couple that with the thyroid scan. So while the radioactive iodine tells you about the function of the gland, the thyroid scan tells you about the geography of the gland. So again, the patient injects radioactive iodine, and but instead of measuring the amount that's uptaken, you just take an image of it to look at the homogeneity of the uptake. So in Graves' disease, the entire gland is overactive. And so you see this like homogeneous uptake. You see on both sides of the lobes that it's very overactive, that the gland is overactive. Whereas in toxic multinodular goiter, there are areas of underactivity and areas of higher activity because those nodules are the areas that are overactive. Okay, so for example, here too, it's like a hot nodule, a nodule that is overactive. Sometimes they call it hot, whereas we call cold nodules underactive. In thyroiditis, you can see here that like hardly any of the radioactive iodine was taken up. And that's because the membranes ended up being damaged and it can no longer uptake iodine and make any hormone. So big thing from this is just to know Graves' disease is homogeneous and diffusely elevated in uptake, whereas the toxic multinodular will just have areas, discrete patchy areas of uptake. And then the thyroiditis will have very little uptake and on thyroid scan won't show any areas of like hot or cold, really. It's just kind of there. Okay. And so these are just pictures again of that. So this is normal. So Graves' disease is diffusely increased uptake. This is on radioactive iodine uptake testing. Toxic adenoma or the multinodular goiter, you can see that one, discrete area where there can be multiple. And then thyroiditis, we have a diffusely decreased uptake. And then here's multiple nodules in the toxic multinodular goiter. Okay. So as I said with our patient, let's say we just decided to do the radioactive iodine uptake and the scan along with the antibody test. So her antibody test did come back positive for Graves' disease, which we thought, she probably does have Graves' disease. And her radioactive iodine showed that the uptake was 90% of the iodine. Normal is less than 30, so it's over-functioning gland. Her scan is shown here. What do you guys see? Is the uptake diffuse and homogeneous, or is it like patchy? How would you describe that? Homogeneous, right? It doesn't look like there's any areas of patchiness. So is that more consistent with Graves' disease or with something like a toxic goiter or a nodules or a toxic adenoma? Graves' disease. Yes, exactly. Great. That's awesome. So nuclear medicine is really difficult to understand. I don't understand like all of how it works. So you guys are doing great. Just, joining in and participating and trying to learn how this, these appear. So yeah, great job. So this is like homogeneous. It's diffusely increased uptake. So as far as her diagnosis, what's her diagnosis? Graves. Yep, great. So we've already had she has hyperthyroidism. She has these positive antibodies, and then now, this is proven by her thyroid scan and radioactive uptake as well. So a little more learning on Graves' disease. As we said, the most common cause of hyperthyroidism, there is a female predominance. It's about 8-to-1. The typical age range is, mid-adults. Timeline there. The incidence is about 30 people per 100,000 cases per year. There is a strong genetic component. So 50% of patients with Graves' disease have a family history of autoimmune disorders. So that's exactly what we saw with her sister having type 1 diabetes. It does arise sporadically, but it can be triggered by infection, stress, and pregnancy. And as we'd said, the autoantibodies are those circulating TSH receptor antibodies. And they cause the thyroid hormone production to increase. There is a clinical triad. There's that diffuse vascular goiter. The goiter is what we saw on her exam, but you can also have this, the eye manifestations of Graves' disease, which we'll look at, and this pretibial myxedema. And then you also have the findings and symptoms of, just general hyperthyroidism. So looking at some of these classic symptoms, so this is like the diffuse vascular goiter, similar to what we saw on her exam. It's often like uniformly enlarged, and you hear like a bruit, which is like turbulent blood flow at the superior portion of the lobes, because as the gland enlarges, it increases the vascularity as well. So sometimes you can hear that. Graves' ophthalmology. What I want you guys to learn about this is, and then you guys might have seen this before in people that have Graves' disease, or maybe, relatives, if or if you know anybody that has Graves' disease, they can get these protrusion of the eyeballs, which is called exophthalmos. And what I want you to know about this is because of the action of fibroblasts. So within the orbit, what happens is there's actually TSH autoantibodies within the orbit as well. And what it does is cause an autoimmune reaction and stimulates lymphocytes and cytokines to come in. And when those cytokines, which are inflammatory markers, and those lymphocytes come in, they cause inflammation, and they cause the fibroblasts of the eyes to secrete like extracellular matrix components, such as hyaluronic acid and other things that draw water into the extraocular muscles. And when you draw water in, then that can cause the protrusion of the eyeball. So all of this is because of the fibroblasts being stimulated to make some of those extracellular matrix components and draw water in. That's kind of what I want you to know, like to associate fibroblasts with this eye manifestation. And then last but not least, this pretibial myxedema that we see. So similarly to how the fibroblasts in the orbit can be stimulated, so can those of the dermis. And so they can produce all of these extracellular matrix components that stay in the connective tissue of the extremities and form this non-pitting edema, as well as little plaques on the anterior and lateral aspects of the legs. So if we had someone with Graves' disease that came in and they looked like this with their eye exam, they had the diffuse goiter and they had this, and then we also proved that they have elevated thyroid hormones, then we can just go on to treatment. We wouldn't have to do, anything else or even test the antibodies. So I guess I didn't change this. But anyway, so treatment of Graves' disease in the acute setting, you can use medications such as beta blockers to help control the symptoms like heart rate. But otherwise, what we do is we have like 3 camps. We have the anti-thyroid drugs. So those help to like achieve a normal function thyroid state. And usually patients with small goiter or mild hyperthyroidism can take these drugs for like 1.5 years and undergo remission. And then you can take them off the drug. Sometimes that doesn't work, and if you have a bigger goiter, like a little bit bigger goiter than that, in more serious symptoms, then you could do radioactive iodine ablation. So similar to how the radioactive iodine uptake scan was used to to diagnose the Graves' disease, this is actually used to treat it. So you do a higher dose, and because the thyroid uptakes that iodine, what it does is just destroy the cells. And so you can use this too as a treatment option. And then last resort, this is not good for people with that are pregnant or breastfeeding. So you could do surgery for like pregnant people that, might not want medications, they just want surgery. Or for people who don't want this radioactive iodine ablation, or they have this really large goiter that might be obstructive. So this is also an option. You can take out the whole thyroid, or you can take out some of the lobe. But the problem with this is that afterwards, and sometimes with radioactive iodine ablation as well, you'll need a thyroid replacement, right? Because then your thyroid is going to be gone. So then you're at risk of being hypothyroid. So medications, radioactive iodine, and surgery. Here are just some general side effects of treatment. So those medications, the antithyroid medications, can have some consequences like a rash, decreased granulocyte count, possibly a teratogenic effect. So in the first trimester of pregnancy, you want to use one over the other. And then talking about the radioactive iodine, you might think radioactive iodine might be risky, but it really does have minimal risk. You want to avoid it in pregnant patients, but overall, like the risk is pretty low as far as like, exposure to radiation and that kind of thing. But it can potentially worsen patients' eye manifestations. Okay. So with our patient, she opted to begin the antithyroid medications because she's not yet sure about the radioactive iodine treatment, and she doesn't want to, potentially become hypothyroid and have to be on long-term replacement. So she started on the antithyroid medication methimazole. At her 1 month follow-up, she reports her symptoms have improved. She's tolerating the medication without side effects. Her TSH is increasing and her T4 and T3 are decreasing. So she's starting to get back to normal levels. And she wants to continue the medication, and she'll be seen again for follow-up and repeat labs in 3 months. Okay, and that's the end of our case. I know at the end there, it was a lot of like learning stuff, so me talking, but does anybody have any questions? You guys did a great job at participating in learning all of this stuff, and trying to think critically about what could be causing what she presented with.